Trauma is, at its core, a memory that never finished being filed away. Instead, it is a physical failure of the brain's internal filing system, rather than a vague emotional reaction. In a healthy brain, a threat triggers an alarm. You react, and the alarm shuts off. In post-traumatic stress disorder, the amygdala, the brain's threat center, gets stuck in the on position. It keeps firing at the faintest reminders of a past event, long after the physical danger has passed. To treat this, therapists rely on a difficult clinical truth. The only known way to heal a traumatic memory is to face it directly, process the emotions, and teach the brain that the event is over. But looking directly at the memory is exactly what the traumatized brain is wired to avoid. The prefrontal cortex, which normally acts as the emotional brakes to rein in panic, is underactive. The brakes fail, and the alarm won't stop ringing. We are asking people to cure their trauma by doing the exact thing their biological defense mechanisms have made impossible to endure. When a patient sits in a traditional therapy room and tries to revisit a horrific event, their biology turns against them. Their heart races, they are flooded with shame and terror, and the nervous system completely overwhelms them. This chart illustrates the window of tolerance, the narrow emotional zone where a person is regulated enough to engage with a memory. In severe PTSD, that line rarely stays in the safe zone. It spikes too high into panic or drops too low into numbing. If a patient is either re-traumatized by fear or entirely checked out, trauma processing stops. You cannot heal a memory you cannot bear to look at. To get around this biological wall, researchers started looking for a specific tool to temporarily rewrite the rules of that emotional defense system. They found it in MDMA. Most people associate the molecule 3,4-methylene-dioxymethamphetamine with dance floors and the recreational drugs ecstasy or Molly. In a clinical setting, it operates in a category of its own. It rarely causes hallucinations or ego dissolution, like psilocybin or LSD, and it lacks the pure energetic drive of a standard amphetamine. Researchers classify it instead as an empathogen. Its primary mechanism acts on serotonin. Normally, a brain protein called a transporter acts like a vacuum to clear serotonin out of your neural synapses. MDMA reverses that vacuum, pumping serotonin out and flooding the brain with it. The patient doesn't lose touch with reality. Instead, this surge creates a profound state of lucidity, warmth, and openness, entirely shifting how they relate to their own internal emotional landscape. The serotonin surge also triggers a cascade of hormones, primarily oxytocin, the neuropeptide responsible for social bonding and trust. MDMA hijacks the brain's natural machinery for feeling safe and connected, and turns it all the way up. At the same time, this neurological model shows the fear circuitry. The drug reduces the hyperactive amygdala's reactivity, turning down the internal threat alarm. While quieted, the prefrontal cortex sends a stronger signal down, effectively restoring the emotional brakes trauma had worn away. Fear goes down, and a deep sense of trust goes up. This specific neurochemical state artificially widens that narrow window of tolerance, holding a patient grounded, present, and calm enough to finally examine their trauma. This state takes advantage of a memory quirk called the reconsolidation window. Human memories are not permanent video recordings. Every time you recall an event, the memory briefly becomes editable before your brain stores it away again. By bringing up the trauma in this temporary state of chemical safety, the brain undergoes extinction learning. It forms a new, safe association with the memory and strips away the attached layer of terror. The memory of what happened remains completely intact, but when the brain resaves it this time, it is filed away correctly as a historical event, stripped of its power to trigger a biological panic attack. This mechanism moved out of theory and into clinical reality with 2 rigorous Phase 3 trials, where pure, precisely dosed MDMA was paired with intensive professional psychotherapy. This chart compares the trial outcomes for patients with severe, often treatment-resistant PTSD. Following 3 sessions of MDMA-assisted therapy, roughly 70% of participants no longer met the diagnostic criteria for PTSD, compared to about a third to a half in the placebo groups. The drug does carry physical risks. It raises heart rate, blood pressure, and body temperature, creating hazards like overheating or dangerous drops in blood sodium. This is exactly why the protocol relies on strict clinical supervision and careful patient screening. Even with those physical risks accounted for, 2 large trials pointed the exact same way. They provided hard statistical evidence that this dual neurochemical action actually works. Then, the clinical data hit a regulatory wall. In August 2024, the FDA reviewed the Phase 3 data and declined to approve MDMA-assisted therapy, asking for another full trial. Regulators raised several issues, starting with the difficulty of conducting a truly blinded study. In standard trials, neither the patient nor the doctor is supposed to know who got the drug and who got the placebo. With a substance that floods your brain with profound empathy and physical warmth, participants obviously know which group they are in. The second major hurdle is structural. The FDA is designed to evaluate the safety and efficacy of pure chemical interventions, like a daily pill. MDMA's success is inherently tied to hours of accompanying psychotherapy, and regulating talk therapy falls outside traditional FDA frameworks. This rejection doesn't erase the results of the trials. It exposes the massive difficulty of fitting a complex drug and therapy package into an approval machine built for simple, standalone pills. The path to making this an approved medicine is currently stalled by regulatory hurdles, but the neuroscience remains solid. We know how the fear circuitry breaks, and we now have proof that it is biologically possible to lower the alarm, open the memory, and finally face the unbearable.